to our next speaker, Dr. RUPAK BISWAS, and he's going to talk about phaco in vitrectomized eyes.
Thank you, Dr. Ghosh, for inviting me into this session. In phacoemulsification, you are not doing phacoemulsification, you are not doing anything extra in that. What is here lies how the situation is different from a normal cataract, a normal cataract patient. So that's what we need to be more precise about this talk. So doing cataract surgery, probably I will come to that part also, so how it is little different. But again, most important is that I don't have any financial disclosure regarding this topic. So the points to remember is that here there is no vitreous support. There is always a zonular weakness. And before that, let me tell you, if you are the vitreous, you are the ear surgeon and the cataract surgeon. So if the previous surgery is done by yourself, so you know that what has been done earlier also, so you are much more confident about the situation. So if it is not there, then probably you need to get the detail of it. So there is always a possibility of multiple manipulation and leading to the zonular weakness. These two combinedly leads to a situation which is high myope-like condition because the AC goes down during this period. So, and we need to address the posterior capsular status, the retinal status, presence of silicone oil is there or not, and the biometry setting accordingly. So these are the basic point. If we remember that we need to go for these, then it becomes much easier. Then again, let us go back to the point of history taking. So first thing is that how long back was this cataract surgery was done? So on an average, in an uncomplicated phakic eye vitrectomy, so around an year is a common time when usually it starts. Average time is 1 year later. But if you see the cataract has developed much faster or much earlier, and the cataract progression is much faster and becomes like white cataract, so probably there is always a disturbance in the lens capsule. So that's why it has progressed faster. So what was the exact surgery was done earlier, whether it is a vitrectomy with endolaser or a epiretinal membrane handling, or a silicone oil was given, or silicone oil is removed. So then immediate post-VR surgery, before development of cataract surgery, what was vision? If it is documented there, then it gives you a kind of an information for the counseling of the patient. Post-cataract surgery, what is the visual prognosis? And any lens touch history, if you can document it of, or silicone oil used or it has been removed. So these are the history precisely we should take before planning for the surgery. Points for the clinical examination, again, it's everything is like a normal routine what we do in a slit lamp examination, corneal status, AC depth. But here it is of even more important, because with this you can visualize much more grave situations, so that you can be prepared during your cataract surgery. The pupillary dilatation, zonular status, and posterior capsular integrity. So these are the things we should start seeing in slit lamp examination. Again, continuation of that, the density of the cataract, whether it is a centrally nuclear sclerosis, which usually develops over a period of time. The most common type is though posterior capsular cataract, but type of cataract, whether it is a totally intumescent cataract, so that also gives you, and whether there is any presence of phacodonesis. So these are give you much more of information about planning. Regarding ophthalmic investigation, ultrasonography, when the visualization is not proper, posterior segment visualization, then ultrasonography gives you good information. But if there is significant amount, if there is silicone oil, then that has to be addressed properly. Ultrasound biomicroscopy can give you an idea about the zonular status and biometry according to the session, according to the situation. If there is silicone oil, so that mode should be different, or if it is due to, or it is dense cataract, then probably optical biometry cannot be possible, so ultrasound biometry has to be used for that. So for the prognostication, again, here is most important is that lens status, or accordingly the IOL related prognostication. So whether you will be able to put IOL or not in an intumescent cataract in a vitrectomized eye, there is always a chance of runaway rhexis. So these are the situation we should, as Dr. Mukherjee was telling, so precisely prognostication of that particular case is very, very important, and that should be topped up with the previous retinal status, how it was pre-cataract. development. And by this, if you have a little extended chat time to explain to the patient that this is the situation, I think that becomes much more easier for us to overcome the situation. And whenever is possible, if a written consent is available, then we can do it. Thank you. Thank you so much.
I think that was great. You bridged the gap for a phaco surgeon who is facing such a situation. I have one thing to understand. What are the nuances of a cataract surgeon like me? What different procedure would I take if it is a silicone with silicone and without silicone oil eye?
I mean, you are talking about in presence of silicone oil.
In presence of silicone, what is the...
Yeah, that's exactly. I was just showing, if I can explain with this video slowly. So this is a video which is showing you can use either of the eyes to do according to the presence of it. So the presence of silicone oil, when you combinedly, I'll just stop it here. When you plan for combined surgery, silicone oil removal and cataract, so it is better to do the cataract surgery first and then to do silicone oil removal, because you are always getting a good amount of the support and cushion over which you can do the phacoemulsification very properly. But yes, again, you need to remember here, there can be always a zonular weakness through which the oil bubble can come up to the AC and can cause sometimes cause hindrance. In that situation, ample use of viscoelastic and taking that silicone oil bubble and again redo the surgery. And always in a vitrectomized eye, with or without presence of silicone oil, the low parameter phacoemulsification is what exactly we should look for. Slow phaco, what we do it.
Exactly. And preoperatively, the biometry, with silicone or without silicone oil, the viscosity of the silicone oil needs to be fed into the biometer so that we get a adequate, biometry done. That was excellent, Dr. Rupak. If we don't have any more questions, I think we'll request Dr.